individuals caring for or interested in the problems of children affected by drug-resistant tuberculosis, and really tuberculosis in all forms. If you're interested, we have a web page, which is Evgenia can post, as well as an email address for any questions or comments. But anyone who is interested is welcome to join the Sentinel Project. We have a number of task forces that are looking at things varying from research on children with drug-resistant tuberculosis to estimating burden of disease to pediatric drug formulations. And finally, one of the task forces that I work closely with is the Capacity Building Task Force, in which those of us who have some experience treating MDR-TB are working with our colleagues around the world to ensure that more providers at all levels understand some of the intricacies of diagnosing and treating children exposed to, infected with, and sick from MDR-TB. So it's actually really exciting. And so today, I guess the one last thing I would just sort of like to plug is that, we know that children who are treated for drug-resistant TB actually do very well. We're certainly not treating enough of them, but they tend to have higher cure rates than adults, and they tend to have fewer side effects. But the biggest problem that we face really is in making a diagnosis in these children. And I think that's why today's webinar topic is especially important, in which Dr. Elizabeth Haraz and Dr. Carlos Perez-Velez will be talking to you about a technique for better sampling gastric aspirate fluid so that we can make a bacteriologic diagnosis of tuberculosis and drug-resistant tuberculosis in children. So it gives me great pleasure to introduce them. Dr. Haraz is an infectious disease physician and public health expert who's completing her third year of training with me, lucky me, at Case Western Reserve University in Cleveland, Ohio. Dr. Haraz has been working with the Sentinel Project, particularly the Capacity Building Task Force, and has several years of field experience both with HIV and TB in Senegal and West Africa, where she lived for more than 2 years, and then in South Africa as well, where she worked as a trainee. She is also engaged right now in several research projects on tuberculosis and drug-resistant tuberculosis in Uganda, some work in South Africa, and then also in the country of Romania. So it's really a pleasure to have Dr. Haraz with us today. She'll be working and speaking with Dr. Carlos Perez-Velez, who is truly one of the world's international experts on diagnosing tuberculosis in children. Dr. Perez-Velez wears many hats, but he currently finds himself right now at the University of Arizona, where he's an assistant professor, but also works as an infectious disease attending for both adults and children at the Banner Good Samaritan Hospital. He's on the steering committee of the Sentinel Project for MDR-TB and has trained extensively in both TB and MDR-TB at National Jewish Hospital. He often is called upon to collaborate with the Centers for Disease Control and the World Health Organization, and has done a lot of interesting work in South Africa, in Kenya, and then also in Bangladesh. So really, I don't think you could ask for two better people to be showing you this video. One other brief group of people to thank are our colleagues at from Dhaka, Bangladesh, where we held a capacity building workshop last summer, and they were kind enough to work with Dr. Haraz and Dr. Perez-Velez to produce the video that you're seeing. And my final comment is that this is the world debut of the video. Dr. Haraz and Dr. Perez-Velez have been working very hard on this, and I know they're excited to show the video, but also to get your feedback. If there are things about the video you think were fantastic, let them know. If there are things you think could be changed or edited, please also let us know. And so I'm going to turn things over now to my two esteemed presenters, and I hope this is a great session. I know I've learned a lot from both of them, and I'm confident you all will as well. Thank you.
Hello, everyone. This is Elizabeth Haraz. So I'd like to thank you all very much for joining us today. We're really excited to have you with us. I think we can all agree that childhood tuberculosis is an under-recognized, underdiagnosed, and undertreated disease. The World Health Organization estimates that children account for 500,000 new tuberculosis cases annually, and that at least 74,000 children die of tuberculosis each year. And it should be noted that these numbers do not include HIV-positive children. So, and even the World Health Organization recognizes that these numbers are likely much higher, as children so often do go underdiagnosed. One of the main difficulties of bacteriologically confirming tuberculosis in children is that it is difficult to get a culture positive respiratory specimen because young children have difficulty coughing up a sputum sample, and tuberculosis is a possibly bacillary disease in children, limiting the culture positivity rate of samples. So not only is this difficulty with diagnosis a tragedy for the child, who may be misdiagnosed with another illness, or who may not be treated correctly if the child has a multidrug-resistant tuberculosis and there is no culture isolate for drug susceptibility testing, but this is also a tragedy within the public health system, because if children are underdiagnosed, the problem continues to be underrecognized, and resources that should go to treating childhood tuberculosis instead go elsewhere. So, in an attempt to help improve the tuberculosis diagnosis rate among children, we have made this skill-building video on gastric aspiration in children. Our hope is that its guidance will be helpful to you in your quest to bacteriologically diagnose pulmonary tuberculosis in children. hello everyone. So that's the end of the video. We'll leave these key points up here while we have our discussion. So I get started discussion with some of the questions from the audience. I see that one question we had is that can a respirator be used over several days, as it's expensive and not easily available to some people. So it definitely can be. We use them over several days here as well, as long as it doesn't, as long as it stays in good condition, doesn't get soiled or overly sweaty. You can continue to use them as long as they're in good condition. I assume you're referring to the N95 respirator. So, while we wait for some other questions to come up, I think there were some points that we thought that we would like to bring up that might be relevant to actually performing the gastric aspirate. So I don't know, Carlos, if you want to discuss. I think if people in practice and reading the literature, there's often in the papers, they say, or the dogma is that you need to do 3 consecutive samples, and I know in our video we only discussed getting 1, so maybe you want to discuss that?
Yeah, sure. Well, firstly, I'd just like to emphasize that, that the most important point is getting a good quality specimen, and I would say similar to sputum in adults, the first sample will probably be positive in approximately 60% of cases that will, are potentially bacteriological confirmable. With the second sample, you could probably increase that to around 85%, and with the third one, you'll get closer to 100%. So you definitely have the highest yield from the first one, but I do think it's justified to get a second and third one. The exception, I would say, is if you could get a combination of types of specimens, for example, induced sputum, stool, nasopharyngeal aspirate, string test. What has been revealed in literature is that combinations of specimens, 1 or 2 of each, have a higher yield than to get many samples of one type of specimen.
It looks like we also have a question about the recommendations of the volume of buffer to add to the
titrate as needed. So very often the range of the pH of the gastric aspirate, is from anywhere from as low as 1 or 2, usually no less than 2, and sometimes as high as 5 or 6. So the higher the volume, the more drops you'll need, and the lower the volume, the less. And of course, the lower the pH, the more likely you'll need. I make this point only because sometimes you can over-alkalinize a sample, and one of the concerns I've seen is that under programmatic conditions, it's not unusual to have the vials or the Falcon tubes or the containers come already with a almost an arbitrary volume of sodium bicarbonate or other buffer solution, and the gastric aspirate is just emptied into it, and when you measure this in the lab, many times, very many times, the pH is now 14, which can be potentially as detrimental as a very acidic pH. And then the other method that is used is kind of a proportion method, whereby, a guideline I've seen might say, for every one part of gastric aspirate, use, X parts of the solution. But even that's variable, because the volume, the pH varies by the volume, whether or not you had to do a lavage, what concentration of the buffer is being used, the amount of drops, etc. So there's definitely some variability, and so my final recommendation is to be methodical and just to a titration method. Yes.
We also have a question about if the specimen has some blood in it, can it still be used?
Yes, definitely. There can be, some confounding effects on nucleic acid application test, PCR tests, with blood, but certainly for culture it wouldn't be an issue, and if it's not frankly bloody, also for microscopy. But I would argue even for PCR, certainly well worth using.
Yeah, let's have another question. The question is, if there's undigested food in the samples, do you recommend waiting a certain period of time to collect another, to wait to get the sample or recollect the sample?
Yes, yeah, that's not unusual. I really endorse the technique of placing the nasogastric tube in the evening, 3 hours after the last meal, so that when you come in the morning, or when the specimen is collected in the morning, hopefully well before the child awakens. It's not unusual that, especially very young infants who have to be fed, every 2 or 3 hours, a mother, despite asking her to not feed the child, may do so, and you find yourself aspirating milk. In these cases, I actually stop the procedure. There's a risk that the stomach may be more full than you may realize, and risk the chance of aspiration. And of course, the sample wouldn't be that good. So I would just hold, comfort the child and the mother, reassure them about the procedure, and I'd ask when that last meal was given, and maybe approximately 3 hours later, I'll reattempt to collect the specimen. In some cases, it's very dilute, meaning you do see food particles, but you have very good samples. This of course is a contaminated specimen to begin with. Gastric contents is not sterile. So we're not looking for a sterile sample, but if the amount of gastric contents is the majority, food, I would just probably, discard it.
All right. We also had a question about reviewing the types of the type of nasogastric tube. I think there's not a specific nasogastric tube that needs to be used, like not a specific brand, but just to review from the video. So we've found that the best characteristics of a nasogastric tube is that it should be somewhat firm and non-collapsible, so that when you're sucking back the fluid, obviously it doesn't collapse. If there are at least 4 holes at the bottom, we find that works well. It keeps the tube from clogging, and that it has a nice coating on it that makes it easier to put in. And then having a cap, so that especially especially if you've placed it overnight, it's not going to leak. So if you can find a tube that works well, I think it really makes a difference. And I think we found, well, Carlos has looked a lot more than I have, but has found that a good nasogastric tube makes a big difference in the procedure and doesn't necessarily cost more than a one that isn't so good. Is that right, Carlos?
Yeah, absolutely. I'm very sad that in many hospitals, particularly public hospitals in many developing countries, I think the least expensive tubes are purchased, and unfortunately the quality or lack of quality shows these tubes tend to have less holes, the size of the holes are smaller, the tensibility is weak, and they easily collapse, especially if you use a large syringe, say like a 20, 30, 50 ml syringe. It's so powerful it collapses the tube. They're often very short, so the tip is almost right outside the nose, so it's less easy to manage the procedure. Sometimes the tips are not so nicely smooth, so they actually cause more trauma. I could go on. They don't have caps at the front. So yeah, if someone has questions about that, please send them to us, and I'll try to direct them to better resources. By the way, I've been amazed at the very small difference between a high quality and a low quality. You would expect the price to be significantly higher. And many times, not only is it very little more, but if you buy by volume, high volume, you may even get them. I have purchased them for much less than the cost of the cheap ones.
We have another question about any tips at preventing the child from removing the nasogastric tube if placed the night before.
I love that question, because that question suggests that the person asking it knows that in reality, any self-respecting child, as I say, is going to want to take that tube out. So I play with the child, and I pretend that we're boxing, and I put boxing gloves on, which are basically, I'll put some cotton gauze in the palm of the hand, close the hand, and then again with gauze, wrap it around, and then put tape at the wrist, so it's kind of like a self-made boxing glove. And this prevents, of course, the child from being able to extend and flex the fingers and be able to take out the tube. The other thing that I do is I secure it twofold. Number one, I put a paper tape on the skin. Then on top of the paper tape, I put the tube which goes from the nostril to the inferior lower part of the auricle of the ear, so just around the temporomandibular joint, so that it doesn't bother the child when he sleeps, if he were to sleep on that side. And then on top of that, I use a very strong tape, one of those kind of cotton, I forget the name, very white strong tape that will sit on the paper tape. And I do not like to use that strong tape directly on the skin, because when you take that tape off, you unfortunately sometimes injure the child and take off a layer of skin. So these minute details, in my experience, make the difference between whether the mother is going to let you place the tube the next day or not. So all the care that you take can go a long way. So thank you for that question.
Yes, we have actually another really good question, which I think was one of the points we wanted to make with this presentation. And it says, the question was that our video made a complex procedure seem that it can be conducted in lower level healthcare facilities and resource-limited settings. And then it says, can it be conducted by nurses in resource-limited settings? In my country, the Ministry of Health plans to roll out the technique to lower-level facilities. I'll let Carlos expand more on that, but I think one of our points, and that we'll stress at the end of this presentation, is that we really do think that this is, a fairly easy procedure, and that as long as somebody is trained correctly, be that a nurse or another healthcare provider or a doctor, that they really can do this procedure well. I don't know, Carlos, you want to expand on that?
Yes, I cannot emphasize enough that one of the advantages, for example, of this procedure, the gastric aspiration, over, for example, a very good alternative such as the sputum induction, is the biosafety requirements. Whereas in sputum induction, by the nature of inducing cough, the risk of transmission, and the recommendation for a more secure procedure room that negative pressure or with multiple air changes per hour, etc. All those standards. Gastric aspiration, although I certainly insist that it does have risk, and that's why a 95 mask should be used and the room should be ventilated, etc. You do not need, I think, such highly stringent requirements. And so I think a first-level hospital, a procedure room, I discourage this procedure to be done in rooms that have other patients in them. I say this because I've seen this done sometimes in the bed of the patient. I do not recommend that. I think a nice quiet room, procedure room, where lumbar punctures or other procedures are often done, is a better place with all the materials there. None of the materials that you saw in the video, I think, are outside of the level of a level 1 hospital. The biggest failure, I think, which is not necessarily limited to first-level hospital, is that this procedure really should be done by, I think, 3 persons. And I'm just amazed that in many countries, the one nurse is asked to do the procedure, and I don't know how it's possible to do it well with just 2 hands. Furthermore, one point I'd like to make is the importance of immobilization, which saves 2 to 4 hands in and of itself, and allows for the repositioning that I think is critical, not only to optimize the collection of the specimen, that is to say, uniting the nasogastric tube with a pool of gastric juice, but also repositioning in the event of vomiting, regurgitation, which could complicate into aspiration if you do not have the ability to reposition the child quickly. So I definitely think this procedure can be done in a first-level hospital.
So I see another question. I think we partially answered. Well, the first part of the question is how many people are needed. So I think we kind of discussed 2 or 3, and that is really best, and that immobilization does help. The other part of the question is that if you cannot get specimens to the lab in 30 minutes, what should you do?
Okay, so that's a kind of a relative point. That is to say, the sooner that the sample is processed, that is to say, neutralized and preserved, the less likely that say in the event that it's acidic, that there's going to be gradual loss of viable bacilli. This does not happen all at once, of course. It's very gradual. You will still get positives if you have a high enough number of bacilli. It's a multibacillary sample. It can last, but I do want to point out that the viability studies, controlled studies in laboratory, has shown that under an acidosis or alkalosis, if you will, the viability decreases, and the preservation in cool temperatures to prevent the overgrowth. I'm sure many of you have perhaps gotten results from the laboratory that says there was overgrowth or contamination, and of course the frustration of having undergone a lot of time and effort to collect the specimen only to find out that the specimen is not a good one because of bacterial overgrowth. So 30 minutes is the recommendation of the guidelines of the United States CDC manual, but let's just say the sooner the better.
Good. And I think there's actually another question that we were going to bring up if it wasn't brought up, but it was. So the possibility of doing this procedure in an outpatient setting, if a night in the hospital is not feasible, and then, what are some recommendations at doing it the best way possible if it has to be done as, in an outpatient setting?
Yes, that's a great question, particularly because in the late 90s or early 2000, a study from San Francisco, Oakland, California, where they showed that they were able to get, comparable yields on an ambulatory basis. The only thing I would say is that, if you can assure the following, I think that's fine. And that's basically that the child arrives to the site where the collection will be carried out while preferably still asleep in a horizontal position, empty stomach, etc. In many developing countries where I've worked and trained others, this is not feasible. Transportation issues, the child arrives awake in a vertical position being held by the mother, and the stomach very often is empty. So it's a lot of effort for this. So I'm not saying it's not recommended, but if you can assure those conditions, then by all means, certainly this is better than nothing. But I do think, and I do not have data for this published, but in my experience, there is a significant improvement when you can do it, place it at night, and be able to do it in the early morning, which I think translates into better, higher bacteriological yields.
Let's see, we have another question about what's the indication for lavage?
Yes, so I actually like to avoid lavages to the extent possible. So, very arbitrarily, speaking with laboratorians who are experts in microbacteriology, if you can get a very high quality, at least 2, hopefully 3 milliliters, but always shoot for at least 5 if you can. There's really no need for lavage. But if you're below 2 or 3 mLs, then I think it's justified. The only caveat I would say is that the most often available solution to do the lavage is a isotonic saline, and it almost invariably contains preservatives. These preservatives are precisely to kill microbacteria, not tuberculous microbacteria that are in tap water and that colonize the mouths of many people. And so you can kind of shoot yourself in the foot by lavaging with a solution that contains antimicrobacterial drugs, which will suppress the growth. So maybe for PCR and microscopy that wouldn't be an issue, but microscopy is practically useless in this setting because the yield is so extremely low, and PCR is not readily available. So you really want this to grow in culture. So the ideal solution would not contain preservatives, and that most usually is sterile water. Sterile water without preservatives would be the ideal solution for the gastric lavage.
All right, we have another question. It says, the question is, in my country, we might need to transfer specimens from one facility to another where tests can be accessed. For aspirates, what is the maximum number of days in transit and temperature for bacteriological yield? Does this affect detection by expert?
That's a good question. I don't have that degree of technical expertise, as far as the exact temperature. I think you could even freeze, and that way, secure or assure the preservation of the sample, and in that way, the duration of the transportation is almost a moot point. The issue is that freezing and then thawing, my understanding is it can affect the yield in, at least if you have to do it multiple times for certain PCRs. I'm not certain if for all. But I would say that, in essence, for PCR in particular, since the viability of the bacillus is not necessary, it should not affect the yield. On the other hand, for culture, it might compromise if the cold chain was compromised at any point. I would say more so because of bacterial overgrowth, not so much because of death of the bacilli.
Okay. So we're almost actually only have a few more minutes left, but there's one more question I think that links into that one. The question is, can GeneXpert be used to assess the gastric aspirate? And it definitely can.
Most definitely, yeah. Recent studies published.
And then
Go ahead, please.
Oh, I just wanted to say quickly. And then there's also, maybe we can expound on that, but I think this question we can answer pretty quickly too. It says, can you also use this technique in coma patients? So people that are unresponsive, and definitely as well, can be used for both children and, so it's really for anybody that can't, cough up a good sample for you. So you can definitely use it in people that are unconscious too. If you want to expand on any of those, Carlos?
Yeah, I would just add that 5 studies, I think last time I counted, there are 5 published studies that included gastric aspirate in children using Expert. And I'd say, it's pretty well validated. The yield was often compared to that of culture as far as diagnostic tests, the PCR and Expert in particular in culture. And number 2, the type of specimen used, some comparing gastric aspirate with reduced sputum, some comparing with nasopharyngeal aspirate with spring test. So I think one of the nice things about the Expert is its versatility as far as being able to use different samples.
Great. So unfortunately, I think we just have one more question I think we can quickly answer. We're not going to be able to expound on it, but there was just somebody who asked about the contraindications for this procedure. So this was earlier in the video if anybody wants to review it, and in the SOP that was sent out. But just quickly, the contraindications are any nasal passageway obstruction, any recurrent or prolonged nosebleeds, that the stomach isn't empty, so it's been less than 3 hours of fasting, and that's due to risk of aspiration, and if the patient's experiencing any respiratory distress. All right. So I think unfortunately it's been a great discussion, but we have to wrap up now. So thank you very much, everyone, for joining us and taking part in the discussion. We really enjoyed it, and we thought it was really great. I would urge you to give us some feedback too about what you thought about the video, because we do want to make it better. I guess one of the main things that came up was about sound. So we were kind of on the fence. We didn't know if maybe sound, if like an voice-over narration would just be more of a distraction, or if it would really be a help. So please let us know in your feedback what you think about that. But I think the takeaway points that we would most like to emphasize from the video are that placing a nasogastric tube itself was really not too difficult. However, placing it with minimal or no trauma and competently managing any adverse events and collecting samples of good quantity and quality requires training and practice. I want to stress, too, that not all nasogastric tubes are equal. Quality and size of the nasogastric tube can impact the quality and volume of the gastric aspirate. An evening placement of the nasogastric tube, followed by early morning gastric aspiration before the child is awoken, tends to offer the best sampling. and connecting the nasogastric tube with the pool of gastric juice by manipulating the nasogastric tube and repositioning the child is key. An immobilization board helps minimize trauma and optimizes positional changes to connect the gastric fluid pool to the nasogastric tube and protect the airway in the event of vomiting. And although usually mild and self-limited, adverse events like nosebleeds and vomiting need to be managed to prevent complications such as aspiration. And that immediate pH neutralization and cold storage preserves the sample for lab testing. So, given that, we would really like to stress that gastric aspiration can be done safely by a wide variety of healthcare professionals, including nurses and other healthcare personnel, and if done well, provides a relatively good culture yield. The nasogastric tube can be done safely by nursing staff. So, given that, we would really like to stress that gastric aspiration can be done safely by a wide variety of healthcare professionals, including nurses and other healthcare personnel, and if done well, provides a relatively good culture yield. The nasogastric tube can be done safely by nursing staff, as these are frequently the healthcare professionals most readily available to care for the children. Gastric aspiration requires less equipment than sputum induction, and with practice, a nasogastric tube can be placed quickly and easily, and the discomfort to the child can be minimized. So again, we'd like to thank you very much for joining us today. We really enjoyed hearing all your comments and questions, and please do take time to fill out the survey and help us so we can improve the video and make it better for people to learn. So we'd really like to improve our video based on your comments. Thank you very much.
And I also would like to sincerely thank our lecturers on our behalf for a very informative and interesting webinar. I see a lot of thank yous coming up as well. And as mentioned earlier, you will be able to view the recorded webinar and related materials on the MDR-TB network website. So that is DRTB.org. And our next webinar in the pediatric series will be held at the end of April. We will be discussing a clinical study of a child with MDR-TB. So please check the DRTB training network for more information on this and also the exact date. We will also have an infection control series in English and Russian languages during the month of May, and registration information will also soon be posted on the website. We would like to ask you to take a couple of minutes and follow the link that you see right now on your screens and fill out a brief survey that will help us collect your feedback on the video and also improve the training that we offer in general. So please click on Browse to on the link that you see under IT issues and complete the survey. It will only take a few minutes.